Rwanda Statistical Yearbook 2024. Trends in Demographic and Health Indicators. Written by Gabriel Ndayishimiye. Introduction. The data highlights what appears to be significant progress across several health indicators, such as reduced fertility rates, improved vaccination coverage, and declining maternal and child mortality. However, beneath these surface-level gains lie systemic contradictions and structural failures that fundamentally undermine the narrative of progress. These so-called achievements obscure glaring loopholes and inequities that expose the regime's failure to address the root causes of disparity. Below is an analysis of these structural gaps, focusing on areas such as fertility, family planning, maternal health, child health, and malaria prevention, which collectively raise serious questions about the effectiveness and priorities of governance under Kagame's regime. Fertility. Teenage fertility rates. Teenage fertility rates, while ostensibly decreasing over time from a high of 11% in 1992, reveal a critical contradiction. A sharp rise between 2010/11, 6.1%, and 2014/15, 7.3%, before dropping again to 5% by 2019/20. This erratic trend is symptomatic of a broader failure in the regime's health strategies, a superficial commitment to adolescent health and education that falters under scrutiny. The inconsistency underscores a deeper structural problem, where interventions are fragmented and fail to address the systemic forces: poverty, lack of access to education, and entrenched patriarchal norms that perpetuate adolescent fertility. Such fluctuations expose the limitations of a technocratic approach to public health that prioritizes metrics over transformative change. Median age at first birth. The median age at first birth, despite its marginal increase over the years, remains emblematic of the regime's structural failures to confront the societal and cultural forces driving early childbearing. Rather than dismantling these entrenched norms, Kagame's administration has merely scratched the surface, leaving intact the systemic barriers: limited access to education, patriarchal expectations, and economic dependency that perpetuate this cycle. This token progress underscores the contradictions of a regime that claims progressiveness while failing to enact transformative policies to empower young women at the most fundamental levels. Family planning. Unmet need for family planning. While the unmet need for family planning has declined over time to 13.6% in 2019 and 2020, this figure remains emblematic of the regime's inability to address structural inequities. The persistence of high unmet need, especially in underserved or rural areas, reflects a system that prioritizes surface-level progress over meaningful engagement with the root causes. Barriers such as inadequate access to contraceptive methods, cultural resistance, and insufficient awareness campaigns are not incidental but structural features of a governance model that sacrifices comprehensive change for statistical achievements. This contradiction, where progress is measured but inequality persists, exposes the superficiality of Kagame's celebrated health reforms. Disparities in modern contraceptive use. Despite the remarkable increase in contraceptive use, surging from 4% in 1992 to 58% in 2019 and 2020 among currently married women, glaring disparities persist among rural women, low-income households, and adolescents. These inequities reveal a regime incapable of addressing the systemic barriers embedded in its health policies. This uneven progress exposes the hollow nature of interventions that tout statistical gains while failing to dismantle the socio-economic barriers restricting access to contraception. Such inequities are not incidental. They are the byproduct of a governance model that prioritizes surface-level achievements over substantive, equitable reforms. The persistent exclusion of marginalized groups from the full benefits of health programs underscores the contradictions in a regime that claims to champion inclusive development while perpetuating structural inequalities. Child health. Stunting. Stunting, a sign of chronic malnutrition, showed a slow decline from 48% in 1980 to 33% in 2025. Wasting, acute malnutrition, and underweight indicators also fell, but stunting remains a more persistent issue. This reflects deeper structural challenges in addressing long-term food security and poverty despite broader health improvements. The missing data for 2010 in these categories might highlight gaps in monitoring systems during periods of significant transition or recovery. Rather than tackling systemic inequalities, the administration's approach prioritizes cosmetic indicators of progress, leaving the root causes, poverty, inequitable resource distribution, and neglect of rural communities, largely unaddressed. This contradiction exemplifies the superficiality of reforms that celebrate marginal gains while failing to address the structural crises at the heart of public health. Wasting. The reduction in wasting from 7% to 1% is presented as a clear success, but this aggregate number can obscure deeper disparities. While the national average appears to show progress, it does not reveal whether certain regions, districts, or socio-economic groups continue to struggle with higher rates of acute malnutrition. For example, marginalized communities, such as those in extreme poverty or displaced populations, may be left behind, even as the overall statistic improves. Aggregating data in this way creates the illusion of universal success while erasing the lived realities of those still vulnerable. The data also lacks temporal context, making it difficult to evaluate the sustainability of this improvement. Without knowing whether the decline in wasting was rapid, gradual, or tied to specific interventions such as emergency food aid during a crisis, we cannot fully understand the long-term implications. A short-term fluctuation may be celebrated as progress, but if the underlying vulnerabilities remain unaddressed, the situation could easily regress in the face of future shocks, such as economic instability or climatic challenges. At the same time, statistics like these risk flattening the human stories behind the numbers. The data provides no insight into the lived experiences of families and children affected by malnutrition. For example, what challenges do caregivers, often women, face in providing adequate nutrition for their children? How do structural barriers, such as unequal access to education, healthcare, or economic opportunities, affect their ability to ensure their children's health? By failing to center the voices of those directly impacted, the data reduces complex human struggles to an abstract figure. While the reduction in wasting is a positive indicator, it must be critically contextualized to avoid complacency. Who has been left behind, and why? What structural causes of malnutrition remain unaddressed? Are these improvements sustainable, or are they vulnerable to reversal in future crises? Finally, where is the human story in this data? Without a multidimensional analysis that examines the interplay of social, economic, and environmental factors, the statistic risks becoming a hollow celebration that obscures the deeper challenges that persist beneath the surface. Vaccination gaps. Rwanda's vaccination rates show consistent improvement from 1980, 86%, to 2025, 96%, with a slight dip in the 1990s, 76%. While this upward trajectory is commendable, the slowing pace of progress since 2014 and 2015 exposes deeper structural contradictions in Rwanda's public health strategies. This stagnation points to a failure in addressing systemic barriers, such as inadequate healthcare infrastructure in remote areas and pervasive vaccine hesitancy. These are not isolated issues, but rather symptoms of a governance model that prioritizes optics over substance. The inability to sustain universal vaccination coverage reveals the cracks in a health system that continues to neglect marginalized communities while presenting an image of progress on the global stage. Maternal health. Maternal mortality ratio, MMR. The maternal mortality ratio, MMR, in Rwanda experienced a dramatic decline from 1,071 per 100,000 live births in 1990 to 203 by 2025. While this significant improvement is often lauded as evidence of progress, it is equally a testament to the disproportionate reliance on international aid and external interventions. The sharp drop post-2000 reflects the influx of donor funding, training of midwives, and community health worker programs rather than the development of self-sustaining, structurally sound healthcare systems. Despite these advances, MMR remains relatively high compared to global averages, exposing the underlying failure to address systemic inequalities that continue to hinder maternal health outcomes. Assistance during delivery. Assistance during delivery rose dramatically from 25% in 1980 to an impressive 94% by 2025, showcasing increased access to skilled birth attendants and health facilities. However, this improvement, while significant, masks deeper structural contradictions. The reliance on top-down policies and international support has led to progress that is unevenly distributed and dependent on external resources. The government's emphasis on optics and measurable metrics often obscures the realities of unequal access faced by rural and marginalized populations. This trend, while aligning with maternal health-focused outreach programs, highlights the superficiality of reforms that fail to address long-term systemic barriers to equitable healthcare. Antenatal care. Although antenatal care coverage, one visit, was already high in 1990 at 92.5%, and has since reached near universality at 98 to 99% by 2025. The stark contrast with 2025, the mere 47.2% of women receiving at least 4 visits in 2025, is a glaring indictment of the regime's governance model. This discrepancy reflects a system that prioritizes the optics of broad coverage over the substantive quality and accessibility of care. Barriers such as geographic inaccessibility, high costs, and healthcare workforce shortages expose the regime's failure to address the structural inequities that hinder comprehensive maternal care. The slow progress in achieving more robust antenatal engagement exemplifies how surface-level metrics are elevated over genuine systemic improvements, leaving marginalized women disproportionately underserved and further entrenching inequality in healthcare outcomes. Adolescent birth rate. The limited data on adolescent birth rates reveals a relatively low but stable prevalence, with rates of 4.2% in 1990 and 4.1% in 2015. While this trend may indicate the success of family planning policies and education campaigns, the lack of comprehensive data points to gaps in monitoring and long-term evaluation. These limitations obscure the full picture of adolescent pregnancies and highlight deeper systemic contradictions. A governance model that prioritizes optics and international acclaim over the rigorous policies and investments necessary to fully address reproductive health challenges. Far from dismantling patriarchal norms and structural barriers, these policies merely sustain the status quo, leaving adolescent fertility issues inadequately addressed. Malaria prevention. Decline in mosquito net ownership and malaria prevalence. The significant decline in mosquito net ownership from 82.7%, 2010, to 66%, 2025, highlights more than operational inefficiencies. It exposes the systemic failures within Rwanda's malaria prevention efforts. While earlier increases in ownership, 18.2%, 2000, 59.1%, 2010, and 82.7%, 2015, reflect successful campaigns driven by government and international programs. The subsequent drop to 66% underscores challenges in sustainability. Issues such as the wear and tear of nets, insufficient replacement programs, and waning funding point to a governance model focused on short-term visibility rather than long-term, equitable health solutions. This decline is emblematic of broader failures to institutionalize robust preventive measures, leaving vulnerable populations disproportionately exposed to malaria. Data for malaria prevalence reveals similarly troubling contradictions. In 2015, the prevalence was relatively low, 1.4% in children and 0.7% in women, suggesting success in public health interventions, awareness campaigns, and access to preventive tools. However, the absence of earlier data reflects gaps in monitoring systems, limiting a comprehensive understanding of malaria trends. These systemic failures in health surveillance highlight a governance approach that prioritizes optics over the substantive infrastructure needed for sustainable progress in malaria control. The lack of consistent data points is not merely an oversight, but a reflection of deeper structural neglect in health systems that fail to address root causes. Data gaps in malaria prevalence. There is limited recent data on malaria prevalence, especially post-2010 and 2011, a gap that underscores the regime's structural neglect of comprehensive health surveillance. This absence of reliable monitoring systems reveals a governance approach focused on superficial metrics rather than substantive health outcomes. Such data gaps are not mere oversights but reflect deeper systemic contradictions. While presenting an image of progress, the regime deprioritizes the essential infrastructure needed to sustain and respond to public health challenges effectively. Data gaps and inconsistencies. Incomplete reporting. The inconsistent reporting of key indicators such as maternal mortality ratio and teenage fertility rates is symptomatic of deeper structural failures within the regime's governance model. This lack of reliability undermines efforts to track long-term trends and evaluate progress effectively. Rather than a technical oversight, this inconsistency reflects systemic contradictions in a governance approach that prioritizes controlled narratives of success over the rigorous transparency required to address public health inequities. The gaps in data obscure the true scale of adolescent fertility issues, enabling the perpetuation of ineffective policies and shielding the regime from accountability. Missing data. Critical areas such as malaria prevalence, post-2010 and 2011, and adolescent birth rates remain glaring omissions in the regime's data reporting, revealing systemic failures to prioritize comprehensive health monitoring. The absence of consistent nutrition indicators such as stunting, wasting, and underweight across survey periods further reflects a governance approach that neglects foundational health metrics. These gaps are not incidental. They signify a deliberate prioritization of superficial accomplishments over the rigorous, transparent reporting required to address structural health inequalities. This selective data curation perpetuates the illusion of progress while obscuring the realities of systemic neglect and inequity. Equity issues. Regional and socioeconomic disparities. National averages, often paraded as symbols of progress, serve as a smokescreen for deep-seated inequalities that the regime systematically fails to address. Women in rural areas and low-income households continue to face structural barriers to accessing family planning, skilled birth attendance, and essential healthcare services. These disparities are not mere oversights, but symptoms of a governance model that prioritizes centralization and optics over equitable resource distribution. Similarly, malnutrition and stunting disproportionately afflict marginalized groups, revealing systemic neglect and the regime's unwillingness to confront the socioeconomic conditions that perpetuate such inequities. These contradictions expose the hollow rhetoric of development that masks the enduring realities of exclusion and disparity. Conclusion. The data reveals a narrative of progress in Rwanda's health indicators that, upon closer examination, crumbles under the weight of systemic contradictions and structural failures. While Kagame's government showcases health achievements to bolster its image, the persistent inequities and inefficiencies in the distribution of resources expose the regime's inability or unwillingness to address the deeper causes of disparity. Teenage fertility rates, a prime example, illustrate the regime's superficial commitment to reforms, with token interventions that fail to dismantle entrenched patriarchal norms or provide equitable access to reproductive education. These gaps reflect a governance approach more concerned with optics than with the substantive transformation necessary to ensure equitable healthcare access. Genuine progress will require not just incremental improvements, but a radical rethinking of priorities to dismantle the systemic barriers that perpetuate inequality and exclusion, especially for the most vulnerable populations.